All right, so good morning, good afternoon, everyone. Welcome to today's webinar. This is the Infection Prevention and Control webinar. And today we are talking about operational. My name is Katie Wilson. I'm an epidemiologist with the International Infection Control Program at the U.S. Centers for Disease Control and Prevention. And I'm helping to coordinate this webinar series for the next 12 weeks.
Au cours des prochaines semaines. Merci de vous joindre à nous aujourd'hui.
Спасибо за то, что вы присоединились.
Reunidos para poder intercambiar experiencias y consejos prácticos.
Registered from over 100 countries, which is very exciting to see us all come together. Thanks to Project ECHO, Dr. Bruce Drumminger and his team for this webinar platform we're using for this series. So quickly to get started, I'm going to review some housekeeping and logistics for today's webinar, which you can also see on this screen. So in this Zoom platform, please use the Q&A function, which is up top on your menu for any questions about today's presentation or the topic. We apologize in advance that we're not able to answer all of the questions we receive. We've picked out some major themes and we'll also be monitoring the Q&A for additional questions we're able to answer. Please use the chat function in Zoom if you have any questions regarding IT or any technical issues. This session is being recorded in all languages, and your attendance today is consent to be recorded. The slides that will be shared today and the video recording will be sent out on a weekly announcement email from Project ECHO, and the recordings will be posted on the Project ECHO website and the CDC website. As a reminder, CME or continuing professional development credits are available. There will be a link at the chat box at the end of the session for the CME credit, and the CME credit is also in a link in the email announcement that was sent out this week. To access the live translation in Spanish, French, Russian, or Portuguese, there is a toggle button on the bottom of your Zoom window with a globe icon that says interpretation, where you can select the audio language. And if Portuguese is not yet available, you can toggle to Spanish, and as the Portuguese interpretation comes online, we will let you know and you can switch over to Portuguese for those who would like the Portuguese interpretation. And that is the end of our housekeeping, so I will now turn it over to Dr. Benjamin Park, who is Chief of the International Infection Control Program here at CDC, for some opening remarks. So I'm going to stop sharing my screen and turn it over to you, Ben. You can take yourself off mute.
Hello, everyone. Good morning, good afternoon, good evening. My name is Ben Park. I'm the Chief of the International Infection Control Program here at the US CDC. And it's my pleasure to introduce the CDC COVID-19 IPC webinar series. CDC works with partners domestically and internationally to improve healthcare safety around the world. We're happy to host this series and hope that it will lead to tangible improvements to make healthcare safer and will bring our community of IPC professionals together. Thank you.
Hi, everyone. This is Fernanda Lessa, and good morning, good afternoon, and good evening, depending on which
Boa noite.
you are right now. My name is Fernanda Lessa, and I am the lead of the prevention team with the CDC's International Infection Control Program. And I will be the co-moderator of this webinar today, titled Triage of COVID-19 Patients, Operational Considerations, and Practical Examples, along with my colleague, Dr. April Bowler. April, over to you.
Thank you, Fernanda. So good morning, good afternoon, good evening to all. I am April Bowler from the World Health Organization, currently in Geneva with the COVID response. So it's a great pleasure and an honor to be here, and we really look forward to today and all of the webinars that are coming up. And great to see the number of participants. I see it's 640, so this is really positive news. So on that note, I'd like to turn over to each of the panelists and ask them to introduce themselves. And we'll start with Maria Clara. Over to you.
Good morning, good afternoon, good evening, everybody. My name is Maria Clara Padovesi. I am Associate Professor at School of Nursing, University of São Paulo, and I am also the Vice President of Brazilian Association of Professionals in Hospital Infection and Epidemiology in Brazil, and I am located in São Paulo. Over.
Thank you, Maria Clara. And then we go over to the other panelist. We have, please, Dr. João Toledo, over to you for self-introduction.
Good morning, April and colleagues. Good afternoon, good evening. This is João Toledo. I'm from Brazil, currently working here at PAHO HQ in Washington, D.C., United States. I'm the lead for infection prevention control and clinical management of infectious diseases under the Health Emergencies Department. Thank you very much. Over.
Thank you so much, João. And now over to Bassem.
Hello, everyone. My name is Bassem Zaid. I'm a medical officer at WHO Regional Office of the Eastern Mediterranean in the IPC, Infection Prevention Control and Antimicrobial Resistance Unit at the Department of Communicable Disease. Happy to be with you.
Thank you so much for all of those introductions. And now I have the great pleasure and honor to introduce the first speaker, Dr. Fernanda Lessa. Over to you.
Thank you, April. I have no financial disclosure with this talk. So the objectives of my presentation today will be to describe the COVID-19 disease burden, to also describe the importance of infection prevention control, or IPC, during epidemics. And finally, to tell you about the goals of this global webinar series that we are launching today. As of yesterday, we had 4.1 million cases officially reported, with 287,399 deaths globally. The most affected WHO region is the European region, in red on this slide, followed by the Americas. Currently, there is no vaccine for COVID-19 prevention. And at this point, it is uncertain when a vaccine will be available in the near future. Therefore, infection prevention and control is your only tool to stop COVID-19 transmission. The goal of IPC is to protect you, healthcare workers, to protect your patients, and also to protect your family and your community. At the end of your work day, you're going to go back to a household for your family and your community. IPC is critical during epidemics in order to prevent transmission of pathogens in the healthcare setting and ensure safe provision of care with maintenance of essential health services. As we have observed during infectious disease outbreaks such as Ebola, MERS, and now with the COVID-19 pandemic, healthcare facilities have the potential to amplify transmission if IPC measures are not in place. And this can lead to fear and distrust of the population on their country's healthcare delivery system. For the COVID-19 response, in order to support and maintain essential healthcare services for the population, we have to limit unrecognized entry of COVID-19 in the healthcare setting And we are do that by triaging patients, which we are going to be discussing today, limiting visitor access to the healthcare facility, and also monitor our healthcare staff. The other way that we can respond to this epidemic is to prevent transmission by training our healthcare workforce and provide adequate supplies. And then finally, to rapidly detect and contain any outbreak of COVID-19 in the healthcare setting before it's spread. WHO has developed several guidance documents under the IPC response pillar. And CDC, in collaboration with WHO, have developed operational considerations to help countries implementing the WHO guidance documents. The goal of the Global IPC webinar series is to provide you practical advices and implementation considerations for IPC for COVID-19. We will have 12 sessions, one each Thursday, for the following 12 weeks. So if your question is not answered today, you're going to have a chance to answer your questions in the following sessions. We're going to have sessions on PPE emergency strategies, healthcare worker risk assessment and monitoring. We are going to have advice use of mask, dead body management, so on and so forth. So please attend the upcoming webinars, and we're going to be sure to answer as many questions as possible. This webinar is not only a collaboration between CDC and WHO, but also a collaboration with several IPC professional societies. Some of them are listed on this slide. Our goal here is to bring the IPC community, frontline healthcare workers, and national government officials together in the fight against COVID-19. And we hope that this webinar can help you all to clarify questions and make a difference in your hospital and your community. We have several COVID-19 resources, both in the CDC and WHO websites, and I recommend you all to look at those resources. Thank you.
Thank you so much, Fernanda, for that great introduction. Sounds like it's going to be really exciting. So now I have the pleasure to introduce Lucy Luvashavi. Sorry for my bad pronunciation, who's going to be speaking about triage operational procedures. So Lucy, over to you.
Hi, can you hear me?
Loud and clear.
Great. Can you see my slides?
Yes. Can you put them to full screen? Maybe that's the only. Yeah, that's great.
You see it in full screen?
Yes.
Great. So my name is Ulzi Lufsansharav. It's a difficult name to pronounce, so it's fine. So I have no financial disclosures to make at this point. Can you see my objectives?
Yes.
Great. So objectives for this presentation really is to describe COVID-19 background.
Sorry, Ulzi, just interrupt. Yeah, it's just a bit slow. Now we can see them. Over to you.
Great. So the objectives are to describe COVID-19 background, definition of triage, and what patients and healthcare workers and healthcare facilities can do in order to minimize risk of infection among patients and healthcare workers. Finally, we wanted to describe some considerations to maintain healthcare delivery as number of COVID-19 cases increase. So COVID-19 is caused by a newly emergent coronavirus, SARS-CoV-2, which leads to respiratory tract infection, including pneumonia. The virus is transmitted mainly by respiratory droplets through sneezing and coughing, but also can transmit by contaminated surfaces. So what is triage? The definition of triage is really sorting out and classifying patients to determine who needs a priority care and where to treat these patients. However, for COVID-19 outbreak, triage is referred to the process of separating patients likely to be infected with COVID-19 from the rest of the patients. Effective triage can prevent transmission of the virus to patients and also to the healthcare workers. So let's discuss what patients can do before and upon arrival to healthcare facilities. Before arrival, patients can inform their healthcare providers if they are seeking care for respiratory symptoms such as cough, fever, or shortness of breath by calling ahead of time. Patients can wear or should wear face mask if available during transport and also at the healthcare facility. Once they arrive at the healthcare facility, they should immediately notify the triage registration desk about their respiratory symptoms and wash their hands at healthcare facility entrance with soap and water or alcohol-based hand rub. Patients also should carry a paper or fabric tissue to cover their mouth or nose when coughing or sneezing. They should maintain social distance by being at least 1 meter away from anyone, according to the WHO recommendations. So now, what can healthcare facilities do to implement triage? Healthcare facilities can communicate with patients before they arrive to triage, set up and equip triage area, set up a respiratory waiting area, establish triage process, train staff on infection prevention and control measures, including proper use of personal protective equipment or PPE. Let's discuss these activities in detail in the next slides. So communicating with patients before their arrival to healthcare facility can include establishing a hotline that patients can call or text, notifying the facility that they are seeking care due to respiratory symptoms. It can also be used, if possible, as telephone consultation for patients. Also, it can serve to inform patients of preventive measures to take as they come to the facility. For example, you can advise them to wear a face mask when they come to the healthcare facility. To provide information to the also healthcare facilities of the facility and also in other strategic areas such as elevators or other waiting areas about respiratory hygiene and cough etiquette. This includes how to cover nose and mouth when coughing or sneezing, disposal of contaminated items in trash bins, and also hand hygiene. So here's an example of the CDC poster for cough etiquette. Now, this picture is showing an example of a triage area on the left-hand side of the slide. You can see a healthcare provider and the patient there. So at the triage area, make sure there is face mask and paper tissue available at the registration desk to give to patients who need those. A waste bin with lid should be available for patients also to discard used paper tissues. Ensure availability of hand hygiene stations to allow patients wash their hands upon arrival to healthcare facility. And also, ideally, we suggest installing physical barriers such as glass or plastic screens for registration desk or reception area to limit close contact between the registration desk personnel and patients. Here, we should also maintain a distance of at least 1 meter to limit close contact between the personnel and patients. So to implement, once you set up this triage area, to implement triage process, you need to assign dedicated clinical staff, such as physicians and nurses, for physical evaluation of patients presenting with respiratory symptoms at triage. Also, you need to train administrative personnel working at the reception area. Healthcare facilities should also have a standardized triage algorithm. So this algorithm should be developed depending on the epidemiologic situation of the country. Let's review an example of a triage algorithm for countries with widespread community transmission. First, in the triage, this triage diagram algorithm should list signs and symptoms which triage staff should check or look for. Here, for example, in this first box, we're showing what signs and symptoms to look, and then it should explain what to do if the signs are absent or present. So for example, on this algorithm, if the symptoms are present, they should place a mask on the patient and separate them from the rest of the patients, and there are other measures they need to take. So once you have such a triage algorithm, now you need to train all of your staff who are involved in triage on how to use it, and then follow this algorithm for every patient entering the facility. Again, a face mask should be given to patients with respiratory symptoms as soon as they get to the facility if they don't already have one. So we know face masks are sometimes in shortage. So if face masks are not available, at least provide them paper tissue or request the patient to cover their nose and mouth with a scarf. A homemade cloth mask can also be used as a source control. Then immediately isolate and separate these patients who are at high risk for COVID-19 in single-person rooms with doors closed or in designated respiratory waiting areas, which we will describe in the next slide. Here, we should also limit the number of accompanying family members in the respiratory waiting area. So on this picture, we're showing you what we mean by respiratory waiting area in the bottom of this picture. So ideally, we said patients should be placed in single-person isolation rooms, but healthcare facilities sometimes don't have those rooms or they run out of those rooms. In that case, we suggest a separate, well-ventilated area to be used as a respiratory waiting area for patients at high risk for COVID-19. This area should have benches or chairs separated by at least 1 meter distance. And this area also should have a dedicated toilet and hand hygiene stations for patients to use. Paper tissue, alcohol-based sanitizers, and trash bins should also be available. And make sure a very clear sign available to inform the location of this respiratory waiting area. Anyone in this respiratory waiting area should wear a face mask. So now let's discuss what healthcare workers can do to prevent infection transmission. Every healthcare worker involved in triage should adhere to standard precautions, including hand hygiene, selection of proper personal protective equipment, respiratory hygiene, etc. Healthcare workers should be trained on and also be familiar with contact and droplet precautions, including donning of PPE. Ensure that environmental cleaning and disinfection procedures are followed consistently and correctly. Stay home if they develop respiratory symptoms such as cough, shortness of breath. So these points will be captured in detail in our subsequent webinars. In the next slide, I will only focus on the PPE required for healthcare workers involved in triage. So healthcare workers who are conducting triage and who do not have direct contact with patients and able to maintain spatial distance of at least 1 meter and have physical barriers installed such as glass or plastic screens do not require PPE according to the current WHO recommendations. So it's shown on this left-hand side. However, even if there is no patient contact, but physical barriers are not available, and also physical distancing is not feasible, if that is the case, then healthcare workers should use face mask and eye protection. So healthcare workers who do come in contact with suspected or confirmed COVID-19 patients should wear gown, gloves, medical mask, and eye protection. So cleaners also in the triage, who are working in the triage and waiting area, should wear gown, heavy-duty gloves, medical mask, and eye protection. Also, they should wear closed-toe work shoes. Finally, let's review what measures can be taken during periods of widespread community transmission. In order to avoid overcrowding at triage and preserve PPE, the following measures can be implemented, such as canceling non-urgent outpatient visits to ensure enough healthcare workers are available to support COVID-19 clinical care. If outpatient visits are critical, such as immunization of the neonates, prenatal care for high-risk pregnancies, identify a separate or dedicated entrance for these patients. Again, reinforce telemedicine or other alternatives to face-to-face visits, postpone or cancel elective procedures and surgeries, expand hours of operation if possible to limit crowding in triage during peak hours. Also, consider setting up respiratory evaluation centers. Designate an area near the facility where patients with fever or respiratory symptoms can seek evaluation and care. Individuals with mild symptoms should be encouraged for self-isolation and also seek care if symptoms worsen. If you would like to learn more about triage for COVID-19, please refer to the documents listed here. And that's all. Thank you very much.
Thank you so much, Ilse, for the presentation. And for everyone, those slides are going to be available via the CDC website, as well as the University of New Mexico Echo Institute website. So now we are going to have some questions for you all. We have 877 participants. And our goal is really to understand a little bit about the practice in your hospital. So I'm going to ask the Echo Institute to please show the first question, and you all can go with your mouse and then check the answer for your healthcare facility. Can we have the questions, the first question up? Okay. So do you use any screening algorithm or questions in your hospital to identify patients that may have COVID-19 at the emergency department? We're going to give you 15 seconds to answer. Okay, time is over. Let's see. I can't see how many answered, so, but let's see the answers. Okay, 89% yes, 11% no. So next question. Does your hospital have a separated waiting area for patients with suspected COVID-19 that are coming through triage or through your emergency department? You're gonna use 15 seconds to answer. Okay, let's see the results. Okay, so it looks like that a lot of you have a separated waiting area. That's great. So the next one, next question. So for patients who come in with respiratory symptoms, what's your hospital policy for source control? And check all that apply. Do you provide a medical mask? Do you provide paper tissues? Do you ask the cloth mask? Do you ask the patients wear alternatives such as bandanas or t-shirts to cover their nose and mouth? Your facilities have no policies established for source control, or your facility has policies established but no supply is available. And let's give 15 seconds, 15 for people to reply. Okay, so let's see the answers. Okay, we still see that 24% of the facilities don't have a policy established. And now it's the last question on the poll, please. Last question. What are the engineering controls you have implemented in your hospital to prevent COVID-19 transmission? Check all that apply. Do you have a physical barrier between registration desk and the patient? Do you have physical barriers, example, curtains between patients in your respiratory waiting area? Do you have an air handling system in the respiratory waiting area, or none of the above? And again, 15 seconds. Okay, so let's see the answers. Okay, so 34 don't have any of the options, but a lot of you have implemented physical barrier between registration desk and the patient. So that's great. So we're gonna go ahead and move on to our next speaker. It's my pleasure to introduce to you Dr. Icaro Boskovski. He is the head of the Infection Control Department at the Hospital Alemão, Oswaldo Cruz, and hospital epidemiologist with the Hospital das Clínicas in São Paulo, Brazil. Icaro, over to you.
Thank you for the introduction, Fernanda, and hello everyone. I want to start by thanking the organizers of this important series and the invitation to be here and exchange the experience. And thank you all connected with us for the session today. Well, excuse me, just let me share my presentation here. Can you all see the slides?
Not yet, Icaro, not yet.
Okay. Now?
No.
Oh, let me, okay. Let me go again to the share button. Okay, share. Okay, Here it
Yeah,
goes.
now we can. If you can put presentation
Okay.
mode. Perfect.
Oh, okay. So I'll show you how we prepared and activated the plan and adapted the structure and flows to implement a triage in our hospital. I have no disclosures for this presentation today. And our objective is to present our experience in implementing the triage system to quickly identify and allocate patients. So this is our hospital. It's a tertiary care. It's a not-for-profit private hospital, predominantly dedicated to complex surgeries and oncology, and is located here in this red spot in São Paulo, Brazil. We admit only patients patients over 14. We have 3 other facilities, but our focus will be on the main center I showed you before. These are our figures. Well, let me say we had the time to learn with countries experienced the pandemic before us. So these are a sequence of events you were completely familiar with, but at late January, right when that was the moderate risk of dissemination, and our Ministry of Health activated the Center for Operation Emergencies, we had our first meeting to plan the response. So the questions that guided the triage plan in our hospital were how to promptly identify symptomatic patients and properly locate them or separate them from patients at risk of acquiring the virus, and how to protect healthcare workers while caring for these patients. We used these documents here that are available and that Fernanda mentioned before, part of the special considerations. Going more specifically in detail of the triage process, we can see it from different perspectives as from the patient, the facility, or healthcare
Es decir, desde la perspectiva del paciente, de las instalaciones y del...
The most spread is the information, the better. So we prepared signs to reach the patients before, at, or after patient arrival in the hospital. And we used different media, and this included information on when to come to the hospital, and if you come, how to protect yourself and others. So the facility provided a dedicated area for suspect COVID patients with separate flow and a separate block, a building to see these patients. And for healthcare workers, they were trained, a dedicated team was trained on infection prevention, occupational safety, and how to identify patients at risk. So here are some of the activities developed during January and February, a time we had no reported cases in the country. Our first case in Brazil was late February. I won't go into detail, but we worked basically in training on identification, patients, infection prevention, and wide communication, and preparing the structure and designing process. And one important thing here was the early establishment of a crisis cabinet with the involvement of the high leadership, what allowed us to take or to make rapid decisions in on what we needed. Training were at first presential in the first meetings, but very early in February we decided not to make presential sessions anymore, so we prepared video sessions, and a trained team was dedicated to go in local, especially in ED, to train how to use PPE, other aspects of infection prevention, and triage aspects. In terms of communication, we use different media, but especially the intranet to communicate with healthcare workers, in the internet to communicate with patients. And we used as well mass media like opportunities in the insertion and television and newspaper whenever we could. So we mapped in this varying moment all the entrances of the hospital, and we planned a communication to communicate to patients at these locations with key methods like wash your hands, use a mask, notify the front desk if you have symptoms, cover your cough, and keep a safe distance. So this is an example of the messages here magnified in an external area before entering the hospital. And it's difficult to see. This is front desk. There are people behind, difficult to see, but here in the circle are supplies like paper tissues and alcohol-based hand rub available. And inside, after entering the hospital, in the entrance hall, the same messages and supplies for respiratory etiquette for patients. And at the entrance of ED department, we had to totem we had already to prioritize, for instance, chest pain. We had a button coronavirus that oriented the patient if had fever, cough, or short breath. Of course, this message was changing over time as the definition changing in the country. But this is to signalize healthcare workers to see the patient that is presenting in the ED department. So during the structure, we allocated, this is the area where we allocated the patients in the waiting areas with chairs. At least this is a room in the right, upper right, with chairs with a distance of 1 meter at least from each other. We have a dedicated here down on the right area for nasopharyngeal and oropharyngeal swabs. We have 2 rooms for triage and a room here in the left for stabilization for critical patients. Note that we don't have in this area negative pressure and in this area. So in this stabilization room, we can have aerosol generating procedures. We chose a room that we can leave a wide open door window to have a natural airflow and minimize the risks. For patients who need admission, we organize a fast track to the bedroom in a way administrative issues is further decided and not in the ED to optimize the patient flow. This is an example of a dedicated room for nasopharyngeal swabs. Okay, this is the triage, the flow chart of the triage we prepared and trained people. So if the patient press the corona button, she or he is driven to the dedicated area that we called here the ED2 is completely apart from the usual care. And a nurse applies during the triage the Manchester score and added of questions, specifically questions of COVID-19. At the end of this process, if the patient is stable, he or she is driven to stay in the waiting area until medical evaluation. Otherwise, she or he is allocated to a single room or go to the emergency room, and the doctor is immediately required to see the patient. Here is just an example of the triage process with an interview, vital signs and temperature, and at the end of the process, the nurse disinfects all the surfaces, equipments, and doffs and change gloves for the next patient. I will not go into detail, but this board to help physicians to decide and allocate patients after triage was very important to optimize the flow of patients to wards or ICU, and especially during the initial times when you have a great number of patients with mild and low risk symptoms, to discharge these patients as soon as possible. We have a dedicated flow to CT scan as well. So the patients, they do not wait in the waiting area of the CT scan, but they wait in the ED department. And when they are asked to go to this area,
could you please turn down the microphones, all of them?
So at this point, we were ready to the battle, but then it was Carnival in Brazil, the biggest party, and this is a picture of the city just 4 days before the first case confirmed in Brazil. So this is a photograph of our waiting area just before this date, and next week we had running to our emergency departments, and all the waiting areas were overcrowded, and many patients at this time were waiting in the corridor, and it was a challenge to manage a safe distance and to optimize the patient flow to liberate this area. So this is some numbers for you to see what happens in terms of patients. In February, we had like 70 patients with travel history, and from March on, we had 2,000 patients in the same emergency department. And you have in the first line here a drop in the overall patients presenting to our emergency department for other reasons. Oh, this is a number. These two lines here on the top shows the movement of patients in our emergency department. This happened, and this running to the emergency departments in early March happened not because, at least initially, a massive contamination during Carnival, but because before these dates, only metagenomics exams or tests were available, and a 10-day waiting time for the results. And after this date, together with the availability of PCR tests at the emergency department, plus the report of cases in Brazil, we had this explosion of patients in the ED department, but it was sustained until 17th March, when the PCRs were over, and we just tested patients that were admitted. So we just this point, and at this point we had the RT-PCR back in our ED department. So we had a slight decrease, but not the same as the month before. At this moment, other units of laboratories offered the tests as well. This is the COVID situation report in Brazil. As yesterday, for São Paulo City, we have 30,000 cases, and in Brazil over almost 200,000 cases. This is not the focus, but just to show you some figures of our hospital, we saw 3,000 patients so far with a 21% positivity of tests. And among the positives, rate of admission of 18%, ICU at 21%, and 7% of death rate. And this high rate of ICU admission probably is related to our median of age of our population is 68 years. Okay, for new approaches, in April, we implemented telemedicine and hotlines for patients to access and discuss management and managing cases and testing. And sorry, telephone calls before scheduling elective surgeries that can't be postponed in that mission. Patients are called and asked about respiratory symptoms, and we are implementing daily training and health workers at entrance as well, and a daily negative notification of respiratory symptoms among patients that are admitted in non-COVID area to identify quickly any onset of symptoms inside our facility. Here we listed some facilitators that we faced during this organization of triage process. I think that the early establishment of crisis committee was very useful with this involvement of high leadership because we could make a rapid decision making and a consistent evaluation of action, and we could change direction whenever need and very quickly. A comprehensive involvement with different areas of the hospital to build this picture was very important as well. And here are some of the barriers that, as it was said before, that came with distrust and panic to health facilities, like fast spread of fake news, and the threat of PPE shortage, and the threat of the health system collapse put pressure on the organization of this care. There are many, but if I could choose some messages, planning with a comprehensive participation of different areas to think of the best way to plan or your triage is a good way of dealing with this, and learning from others' experience and changing and adapting and being ready to change quickly is another important characteristic to face all this, and provide consistent and robust plan of communication with everyone, patients and healthcare workers as well. I will be here to answer questions, but I will be happy to answer any further question by these emails. Thank you.
Thank you so much, Icaro, for the excellent presentation, and thanks for sharing some of your lessons learned and also the challenges that you faced. So our next speaker is Dr. Purva Mathur. She is in charge of the microbiology and hospital infection control services at the JPNA Trauma Center of All India Institute of Medical Services, New Delhi, India. Dr. Mathur, over to you.
So, good day, everyone. I'll be sharing the experience of developing a COVID facility at an Indian hospital. Can you hear me?
Yes, we can.
So, I have nothing to disclose. So the objectives of my presentation will be to describe the burden of COVID in India, understand the challenges of COVID at an Indian hospital, some important lessons of preparedness and way forward for developing countries. So healthcare in India is provided by a government sector that is highly subsidized and by private hospital where patients have to pay for their treatment. All India Institute of Medical Sciences is a public health, tertiary care, teaching and referral hospital of India. It has some 50 specialty centers and departments with an yearly outdoor patient attendance of almost 3.8 million, which means that almost daily around 10,500 patients attend the OPD services. You can see the loaded OPDs on a busy day. There are some 250,000 admissions each year and 200,000 surgeries each year. We have some 20,000 students, 670 faculty and 10,000 other staff. So to convert such a huge hospital to cater to COVID patient was a humongous task, and it required a lot of deliberation, teamwork and close coordination. So currently we have more than 75,000 cases of COVID in India. And for us, the main thing was we started with a very organized plan with a top-down approach where the director of the institute held meetings every day for almost 2 months, where micro-planning was done. Committees were made in which in charges and team were made for the main AIMS hospital, the trauma center, which is now converted to a dedicated COVID hospital, and the cancer institute, which is now also closed for COVID patients only. Duty rosters were made, and all our areas in our hospitals have made duty rosters so that it ensures minimal staffing, and if one of the cohort is of healthcare worker is infected, they go out of duty and there are enough staff for the patients. Rosters for COVID area have been made for 14 days, so they work for 14 days and they go off. After that, we have given health HCQS, the hydroxychloroquine, to every healthcare person in AIMS. So everyone has got HCQS, and we have given everyone personal use mask to all. 25% staff from each department has been relocated to COVID area. So the core departments which man these COVID ICU are the anesthesia, medicine and ID, pulmonary medicine, geriatric medicine, and the other departments have to pitch in the COVID duties. So these are the daily briefings held by AIMS director with the staff, where all faculty, residents, nurses, and technician students attended. And because of these meetings, our first patient came on 3rd April, but by 20th March, we were ready with a basic triage document in which we were very clear how the emergency services will function. The OPD services were closed. 11,000 patients every day. The inpatient services, how the operation theaters would function, we closed down the routine surgeries also. The research staff were given leave. And a dedicated line was made for the employees. Beds were earmarked for employees separately. And then we had a very clear protocol for triaging what will happen when a SARI patient or ILI patient will come, where will the mild patient go, the moderate and the severely ill patient. So we had this triaging algorithm where the patient with COVID symptom would go to a designated area maintaining proper distance, and the non-COVIDs would go to their respective departments. We used alternative methods to reduce exposure of patients and staff in the sense that we initiated a hotline in which every patient was contacted and their routine appointments were cancelled. So we cancelled all non-urgent outpatient care, and this is the circular which was issued in which there was temporary closure of the OPD services. We're now using telemedicine in a large way, which is also used for virtual rounds, and we have postponed elective surgeries. Now, these are the visual alerts which have been posted the facility entry and at everywhere to help patients understand in Indian languages what they have to do and where they have to go when they have suspected infection. So we protect the healthcare staff in the triage area by installing these. This is a physical barrier. This is a glass covered entrance at the triage area, so that there is a physical barrier between the patient and the healthcare worker. We have isolation room and separate ventilated room where COVID-19 patients are placed, so that there is no exposure of the staff. And we have provided mask and face covers to all patients who are visiting these healthcare facilities. A very important component of protecting the healthcare staff was this training which has been given to all cadres on infection control protocols. We have updated guidelines made which are revised weekly, and they are rapidly disseminated via the content provider and the AIMS website. We hold regular webinars and the videos are posted online. So not only at the AIMS portal, but our videos are also uploaded on the Ministry of Health and Family Welfare website. So these are some of the many videos that we have made in English language and our own vernacular languages on every aspect of COVID management and triage and how to deal with patients. So our first patient came on April 3rd, and just before that, we had a very detailed micro planning done on where the patients will come, what will be the flow of movement of staff, biomedical waste, linen, samples. So this is the chief of the trauma center. The trauma center has been converted to a dedicated COVID hospital. So everything was detailed to the last team. And this is the last hurdle that we had. The first patient came to the trauma center on April 3rd, and this is our ICU where adequate arrangements have been made for spacing and everything to prevent infection to the staff. So we ensure that all healthcare workers adhere to precautions at all times. We have adequate access and facilities for hand hygiene. The healthcare workers who are conducting preliminary screening that does not require patient contact maintain adequate distance, that is 1 meter or more. And those who are conducting physical exams are provided all kinds of PPE. We have a separate PPE committee which check each and every type of PPE depending on the level of care and protection needed. The triage area is cleaned every 2 hours. We also have a screening for healthcare workers for COVID. So before they go into a COVID area, we have this form filled and we take the temperatures to see that no febrile healthcare worker reaches the ICU. Then we have the feedbacks from the healthcare workers after they doff off to understand what kind of problems they had and if the PPE were okay. We have a very clear patient flow. The clear policy has been developed. So any suspected COVID-19 patient is kept in one area, which is the screening area. If they are found positive and there are no symptoms, we advise home quarantine. With mild symptoms, they go to a dedicated center, which is separate from the main building. If they have severe symptoms, then they go to the trauma center, which is converted now to a COVID center. If the patient is COVID negative, they go to the respective departments. And the trauma center, as I said, is a dedicated COVID center with facilities of ICU, isolation wards, OTs, and HDU. So this is our triage building. This whole building is used for triage. This was before the patients actually came. Now we have a surge with adequate distance between the bed and a clear flow of patients. Now this is the screening area, which is how it looks now. This is the screening area where patients are non-ventilated, ventilated, on oxygen mask. They're kept there for 6 to 7 hours, which is the turnaround time for reports to come. After the report comes, they go to the respected area. So this is the triage area. The patients of SARI are kept there. You can see that some of the patients are either on mask, the others may be on ventilator. And this is the ICU where adequate spacing is maintained for that 6 to 7 hours, where we do not want a suspected negative to get infected while they are awaiting their reports. Now on the left hand side, you can see this is a separate center. These two towers have been designated only for mild cases. All the cases who turn positive and who are mild are brought to this center in buses or in ambulance, and we have a separate manpower for this. This was the first cluster which arrived, and we have this kind of shield for the initial triage where history is taken. On the right hand side, you see that this is the service for moderately ill and sick, very sick patient, which is the trauma center. This is the ward where the moderate patients are kept, and this is the ICU where very sick patients are kept, where mostly they are on ventilators. So again, the isolation facility, which was developed literally in a period of 30 days, this was actually a trauma ED, which was converted to a COVID ED, where everything was, including the engineering modifications, the space, facility for dialysis, facility for OT. We have actually had 3 cesarean section babies, several surgeries. So all the facilities are there in this dedicated COVID hospital, which has been which has been developed in a very, very short time, and with facilities for exhaust, so that air is exhausted outside. We have this assisted donning and doffing. So in each shift, an infection control nurse is posted, which helps who helps the healthcare workers to doff off, especially for doffing off. So this is the assisted donning and doffing we do. We have also cohorted staff, so only essential healthcare workers designated to care for suspected COVID patients are allowed to enter this isolation area, and we ensure that they adhere to contact and droplet precautions. So this is the AIIMS, All India Institute of Medical Sciences website. On the right hand side, you can see that all information related to COVID, all the guidelines, all the documents, the webinars and the videos are posted for general public, and this deal with everything, including pregnant ladies, babies, children, psychological stress, the latest guidelines, and all these are also uploaded on the Ministry of Health and Family Welfare guidelines. So these are the resources which will be available to all when the slides are uploaded. Thank you very much for the patient listening.
Thank you, Dr. Purva, for the presentation. Looks like that we have now 25 minutes for questions and answers. So I will turn over. April, do you want to ask the first question, and maybe if you have any comments? Okay, so I think I'll go ahead then first. And then the first question that we have here, it is for Ícaro and Purva. Can you comment about concerns of asymptomatic COVID-19 patients that may be coming to the emergency department with other condition? How is your hospital handling asymptomatic COVID-19 at triage? So do you want to answer that first, Ícaro?
Yeah, yes, Fernanda. Yes, we, as I showed, we have a separated triage for these patients, but the questions for COVID symptoms, they are included in the usual triage. Because even the patient may at a time misinterpret or not thinking of their symptoms. Or another thing is the contact with the symptomatic or respiratory symptomatic in the last 14 days is asked as well. If any symptom or contact is present, the patient is driven to the area dedicated to the COVID-19 triage, to the flow goes on. And if not, it's follows the usual triage care. for negative patients as well, as I said, we established a daily negative notification to the infection control department that must be done in all non-COVID units of the hospital. I think it's basically, yeah.
Thank you. And then Dr. Pulver, can you comment about the asymptomatic COVID-19 patients and how are you triaging
yes, so Fernanda,
patients?
thank you. So Fernanda, asymptomatic patients are a huge problem in India because we have had cases where children have presented with malaria. They were malarial parasite positive and they were COVID positive. We have had antenatal cases which have just turned positive. We have cases like tetralogy of Fallot. So comorbidities who are not actually symptomatic for COVID have been tested positive very often. So what we have done is that we have done zoning of areas in India. And so each city has districts and there is zoning into red zone, yellow and green zone. All patients who are coming from a particular zone, which is called the red zone, which means more than 10 cases have been reported from those zones. Any patient who is coming with anything to All India Institute, whether it's pregnancy or it's trauma or anything, they are all tested. So this zoning helps, and this has helped us in detecting a lot of asymptomatic patients in the past 10 days. But slowly we are discussing about testing, because ultimately we have to open our surgical units. So we have to decide on whether to test all preoperative asymptomatics or not. We are actually awaiting for more guidelines, because that is one area where we are seriously thinking whether pre-ops should be uniformly screened, because we have a lot of asymptomatic patients. But basically we follow the zoning protocol. Everyone from a red zone is screened. Thank you.
Great, that's helpful, and you actually addressed some of the other questions about screening prior to surgery. So it looks like that you are all thinking about protocol on that. So that's great. One question that I have here for one of our panelists, Dr. João Toledo from PAHO. What are the risks of reinfection by patients already recovering for COVID-19 from other confirmed COVID-19 cases, especially when they are in the same open ward?
Thank you very much, Fernanda, for the question. I think at this time today we have no clear answer for this question, because as we know, COVID-19 is a disease which history is being under development. That as we know of today, we know that most of the patients that are infected by COVID-19, when they recover, they have antibodies, but we are not sure that these antibodies will protect these individuals from having another infection. As of the other experience with other similar viruses, it seems that these antibodies will protect them. But I think that more important than this is to reinforce, as all of the panelists have already mentioned, are the administrative and engineering control measures to contain COVID-19 outbreaks in healthcare facilities. Over.
Thank you so much. April, I'm not sure if you are on, but
yes,
are you?
Yes, I am. Sorry, I had a problem with my mic.
Okay, do you want to go ahead and then ask if you have any comments or ask the next question?
Yeah, thank you so much, Fernanda, and thank you for all the presentations that were extremely informative and a learning really to see what's happening in country. I think there's just one area, and I also want to appreciate our colleagues from WHO who have put something in the chat box. And just to say that we're talking about triage here today, and I think it is in a more kind of general form, but to acknowledge that there are, two processes. There is screening and triage, and often depending on the language you speak, they can either be, framed under one word. I understand that in Portuguese, triage and screening mean the same thing. while in English, there are quite different processes. So I just wanted to acknowledge that, and screening is a process in which an individual is evaluated to see if he or she meets a case definition. And this is often done during an outbreak, specifically using a quick checklist, and it can be done by somebody who may not be a clinician, and it can also be done at the entrance that we've seen in some of the presentations today and at distance. So once a person is screened positive, they become a suspect case during the outbreak, whatever outbreak it is. And this is also something which was used very much during the Ebola time. Triaging is more of a clinical process, and it really is sorting of the patients based on the treatment that they need and obviously how unwell they are. And just to highlight as well that there are validated tools for triaging. And one of the ones that is very well known and used is the integrated interagency triage tool. So just wanted to add that bit of clarity, but appreciating that today many of the discussions have been about both, but maybe we just haven't articulated that. So on that note, Fernanda, did you want to add anything to that before we go on to ask the panelists some more questions?
No. Thank you, April. Yeah, please go ahead.
Okay, great. So for the next question to Maria Clara, what level of PPE is needed for ill patients in screening and or triage? Over to you.
Thank you, April, for the question. So if the patients are ill, we needed to offer them a mask to protect them to deliver droplets. So this is the PPE necessary for the patients. And always is important also to have them in a geographic separation as well, not only the PPE. Over.
Thank you, Maria. Go ahead.
Go ahead, Fernanda, over to you.
No, thank you. So the next question, it's going to go to Dr. Bassan from the WHO Emerald region. It is related to healthcare workers getting infected with COVID-19 virus, especially in emergency departments. And is that lack of knowledge, practice, or unavailability of PPEs? What's the experience from Emory on that?
Thanks, Fernanda. Actually, there are a number of published articles that have looked into risk factors with COVID-19. And of course, more and more papers and documents are published on a daily basis. Among the listed risk factors so far is contact and or providing care to suspected and or confirmed COVID-19 patients or cases, without, of course, applying precautions, even empiric precautions, before knowing that this is a suspected and or confirmed cases. Some of the other risk factors, of course, include performing certain or specific medical procedures, particularly those associated with or those that are considered aerosol generating procedures, the AGBs, such as tracheal intubation, and of course, or removal of the tracheal tubes, tracheostomy, suctioning of respiratory secretion, particularly open suctioning, CPR or cardiopulmonary resuscitation, and so forth. Some of the other factors may, of course, the suboptimal IPC measures, particularly suboptimal hand hygiene when it is required according to the 5 moments of the WHO, and improper donning and doffing or use of personal protective equipments. Some of the risk factors also that are listed frequently is, even though this is not non-healthcare related, is if the healthcare worker has a positive family member with COVID-19, but this is outside the healthcare. However, WHO has issued guidance on assessment of risk of infection among the healthcare workers, and we are currently developing a case control study and a longer-term surveillance protocol for infection, for COVID-19 infections among healthcare workers, and hopefully when we are collecting more systematic information on this issue, will be able to identify more specifically what risk factors are there for healthcare workers to get COVID infections, but this is what is available in the literature. Over to you.
Great, thank you. So we got like a question via the chat, the Q&A box related to for Ikaru and Purva related to the donning and doffing of PPE for healthcare workers. So the area for donning and doff of PPE at screening and triage. If you can comment on that on your hospital. Ikaru first.
Okay, Fernanda, if I understood the question, you're asking if we have dedicated place for donning and especially doffing after seeing the patient. Is it correct?
Yeah, on your
yeah.
triage area, yes.
Yes. We don't have a specific place. The donning and doffing are in the triage room, and what happens is that we have been, in a adequate size to receive because
nous n'avons pas.
Nós temos a demanda é grande.
When the emergency department was overcrowded. And the professional is oriented to disinfect all surfaces and wash hands before donning again. And we have these rooms, as I showed you in the picture, they have space enough for you to have a dedicated board to have or to keep the clean or the new PPE for our next don. So, but in summary, it's everything in the same room. Yeah. Over.
Thank you. Dr. Purva, anything to add?
So at our triage area, we have designated donning and with a very clearly defined. So and triage area, and it's a unilateral flow, and then they go to the doffing area, and there is a shower which has.
Yeah, the line is breaking up a little bit, Dr. Purva. We could not hear your last comment, the doffing area. Can you repeat?
Sorry, Michael. Can you hear me?
Now we can. We couldn't hear the doffing part.
Yeah, so from the triage area, there is a big doffing area, and there is assisted doffing. So infection control nurses help with the doffing. And then there is so we have made showers mandatory. So after doffing, we have some 12 showers made. Everyone takes a shower, changes the scrub, and then they wear their own domestic clothes. So it's a very clearly defined. It takes a lot of time, but we have given 1 hour extra in their duty. So their duty hours have been curtailed, and we take out 1 hour for donning, doffing, and shower. So that's how we have done.
Thank you. April, it's okay. I'm going to go ahead and continue, move on, or do you want to ask any question on your end that you have received?
No, I think it's good. Continue, Fernanda, over to you.
Okay, so this question to Dr. João Toledo Parro. Besides the obvious PPE and sanitation methods, what other recommendation exists for resource-scarce countries to improve IPC in triage? So in resource-limited settings, what are the other recommendations to improve IPC?
Thank you very much, Fernanda, for the question. I think it's important here again to reinforce what all panelists have mentioned in terms of the compliance of standard precautions at all times whenever it comes to the care of patients, and we have to understand the standard precautions as a package of measures that we are going to provide to the care of patients whenever they are in the healthcare facility, which means hand hygiene every time, respiratory hygiene or cough etiquette, implement a system of triage of patients, or even sorting out patients whenever they have signs and symptoms of acute respiratory illness. And also to mention the implementation of both administrative controls, including sorting out patients, limiting visitors, as the panelists reinforced during their presentations, ensuring adequate use of personal protective equipment and also its rational use. And finally, I think it would be important to mention the engineering controls, establishing simple measures like separating beds 1 meter apart from each other, and having some sort of ventilation system. We know that in resource-poor settings, sometimes it's difficult to have filtering systems or negative pressures, but if we open a window to have unidirectional flow of air, that would help a lot.
Thank you. Yeah, and then Dr. Icaro Boscov shows like the open window in their triage room. So that's good, important point, João. Thank you. Maria Clara Padovesi, what are the considerations for screening at treatment centers versus primary healthcare centers, especially when there is limited PPE?
Okay, thank you, Fernanda. So the principles of screening are the same for treatment center or primary care, any place. So the information that we got from Dr. Purva and Dr. Icaro are examples that we can adapt depending on the resources. So the most important thing is having a good flow of patients and visitors for both situations, and also to have good standard procedures. I saw a question in the chat about the hospitals or healthcare facilities that have more than one entrance. And we saw the example from Icaro, the importance of mapping the entrance and try to limit the number of entrances as much as possible, and have the same standard procedure to avoid that patients or visitors potentially infected to come in without the time for implementing the proper additional precautions. So the principles are the same. So the most important thing is having a group of people thinking how we can establish the physical barriers, how we can establish the system to avoid that patients are together if they have symptoms, and especially, as John Paulo mentioned, the importance of standard precautions. So it's always important to reinforce that it's essential to have hand hygiene resources, so also resources for respiratory hygiene, alerts for the patient. So I think the principles are the same. The most important thing is mapping first and then organize how to implement the triage. Over.
Thank you so much. So we are getting a lot of questions related to the diagnostic tests that you are using in your triage areas, and that's for Purva and Icaro. So I will start with you, Dr. Purva. What's the diagnostic test you have been using in your hospital for triage?
So in India, the diagnostic algorithm is totally revolving around RT-PCR. So what All India Institute of Medical Sciences does is only RT-PCR based, but our institute is also hand-holding some 15 hospitals and medical colleges across India. We have this viral research diagnostic laboratory, VRDL laboratory network, in which we are aiming that each state and each medical college will have capacity for RT-PCR. But in the interim, because all state medical colleges cannot do RT-PCR, The Ministry of Health and the Indian Council of Medical Research is also allowing Gene Expert and TrueNat and CBNat. For Gene Expert, we are waiving off validation, but for TrueNat, if there is any positive, it needs to be confirmed with an RT-PCR. We did validate 3 serological kits for antibody. Some of them were only IgG and some of them were combined IgG, IgM, but we did not find very good sensitivity. So we are not recommending any antibody test for diagnostics. It may be used for serosurveillance or for healthcare worker screening at a later date. But currently it is only RT-PCR, and the government is supporting in a big way to facilitate RT-PCR even in the states and districts and the medical colleges. Thank you.
That's great. So what about in Brazil, Icaro? And in your hospital, what are they doing?
Yes, in the private sector at least, we have here the RT-PCR available, with a time around the TAT of 2 days of 20, at least 24 hours, and we have a quick test in the lateral flow to test antibodies, especially IgG and IgM. Available, but with limited indication, because as many of the patients, they present to the ED before the 10th day of symptoms. The sensitivity of this test is very, very low in predictive negative values. So even though we have it available as well, and we have assays like for antibodies for IgG and IgM as well. Over.
Thank you. Okay, another big question. I think that everyone in the IPC community is concerned with antimicrobial resistance. So the question that came, it is, can you comment how COVID-19 in the hospital setting may affect antimicrobial resistance moving forward based on your current experience? So let me start with Dr. Purva first.
So thank you, Fernanda. What we have seen is that in our hospital till now, we have seen some 624 COVID patients. Most of them are mild. So in mild cases, we are not doing any sampling for microbiological cultures, and we are not giving any antibiotics. So in the center which I showed, which has 2 towers only for asymptomatic or mildly symptomatic patients, no antibiotics are given and sampling is minimal. But in our COVID ICU, we have found that we have a good sampling, and we have found that like in non-COVID setting, India has a very high prevalence of gram-negative as compared to gram-positive organism. So we are seeing that, so we have analyzed almost 25 to 30 blood cultures. The most common organisms are Klebsiella and Acinetobacter, and they are very drug resistant. So we are finding Acinetobacter which are just sensitive to colistin. Their procalcitonin level are high, and most of these ventilated patients are ultimately dying due to VAP and septic shock with microbiologically cultured organisms. So in these patients, we are bound to give broad spectrum antibiotics like piperacillin, tazobactam, and a gram-positive coverage. But so the antimicrobial stewardship implementation is slightly difficult in COVID because there's a lot of emphasis on saving these patients, especially if they are young. So that is the profile at an Indian hospital. Most common are the Klebsiella and Acinetobacter, which are highly drug resistant. From tracheal and blood cultures, we are finding candida in urine, and occasional pus samples, which are again growing Klebsiella. So we have a very varied kind of COVID presentation with all kinds of comorbidities. So we have a good microbiology data, but no antibiotics are being given for mild cases. So probably way forward will be to actually have an antimicrobial stewardship policy even for COVID, because post-COVID, we will land up with a huge problem of these bugs, which are resistant, which are anyway resistant in India.
Absolutely. Thank you. We are running out of time. So Icaro, anything that you want to add?
Yes, well, Fernanda, just to add one in general, we don't have much information about co-infection, bacterial co-infection associated to COVID-19. And despite this paucity of evidence of bacterial co-infection, it called my attention that the proportion of patients receiving broad-spectrum antibiotics is described in a recent review involving 2,000 patients, 72% received at least one antibiotic during his care. So this heavy prescription load may affect bacterial resistance. So I believe that prospective studies on COVID-19 superinfection are needed to guide rational approach and stewardship in this context. This would be very useful.
Thank you, Icaro. I think that I want to thank you all for all the panelists as well as the speakers for answering all the questions. I will now turn over to Katie Wilson for the closing remarks. Katie.
Hi, everyone. Thanks for a great session today. Just some reminders and announcements as we close today's session. Amy has posted in the chat box, not the Q&A box, the chat box, the links for CME credit. So please look in the chat box for those links for CME credit. The link's also in the email announcement you should have received earlier. As a reminder, our next upcoming session is next Thursday at the same time slot, and we will be discussing healthcare facility preparedness and monitoring. Since you registered for this webinar, you will get the announcement for next week's session in your inbox. As a reminder, the slides that were presented today and all the video recordings will be available from Project ECHO via an email every week and on the Project ECHO website and eventually the CDC website. And like Fernanda and everyone said, we look forward to continue learning together as an IPC community, and thank you for joining us today. Thanks, everybody.
Thank you so much.
Thank you. Bye-bye.
Bye.
Thank you. Thank you so much.
Thank you. Thank you. Bye.
Thank you. Bye.
Bye-bye.
Faz uma cara de feliz agora.